It's 0730. A patient's capillary blood glucose is elevated before breakfast, higher after breakfast, and higher again by lunchtime. They report increased thirst and fatigue after eating. When you see a rising blood glucose pattern like this across the morning, what's the main reason behind it? And what's the first thing you should check before you assume it's the patient's usual diabetes pattern? The answer is that the numbers reflect a time-based physiological pattern generated by an underlying pathophysiological mechanism, with contributing factors that can change from day to day on the ward. The first thing you check is whether today has a destabilizer that makes glucose harder to control than usual. Infection or inflammation, steroid exposure, pain and stress response, disrupted sleep, dehydration, altered intake, or a medication timing mismatch. This is diabetes need to know information, connecting what you learn to where you work. It's about readings, timing, and presenting symptoms, and then linking those to pathophysiology, risk, and safe escalation. So let's start with the fastest win. Read the glucose trend. Treat blood glucose level or capillary blood glucose readings as a trend across time. Direction and timing matter. Three readings tell you more than one because you can see whether glucose is stable, rising, or falling, and you can connect that to meal timing and the clinical situation. Pre-breakfast high, after breakfast higher, lunchtime higher again. That's an upward trend. Pre-breakfast elevation often reflects what happened overnight, particularly hepatic glucose output and baseline insulin effectiveness across the night. After eating rises are expected, but a bigger rise suggests more glucose entering the blood and a higher insulin requirement than is being met. A rising trend across the morning suggests the body isn't keeping up, or something today is making glucose harder to control. If the patient feels unwell, looks dehydrated, or the readings keep rising, you treat it as higher risk and escalate earlier because the glucose trend might be part of a bigger clinical change rather than routine variation. Chronic hypoglycemia is not just a high number, it's a chronic exposure that progressively injures tissues with fragile microvascular supply. The key microvascular beds to hold in mind are the retina, the renal glomeruli, and peripheral nerves. Over time, diabetes increases risk of retinopathy and vision impairment, chronic kidney disease progression, neuropathy, and downstream realities such as foot ulcers, infection, and amputation risk when perfusion and skin integrity are compromised. Macrovascular risks sit inside cardiovascular disease risk to heart, brain, and limbs. Hypertension often coexists because it's part of a clustered cardiometabolic risk alongside dyslipidemia, central adiposity, endothelial dysfunction, and chronic inflammatory signaling. This matters for nursing because it changes what safe looks like. Safe diabetes care is not just lowering a number. Safe care is recognizing tissue vulnerability and protecting kidneys, nerves, eyes, and vessels early, while avoiding treatment harms such as hypoglycemia and electrolyte disturbance. When you hold that perspective, you stop thinking fix the glucose and start thinking stabilize physiology and protect tissues. Working through a mental checklist focuses your reasoning when you don't yet know the entire clinical picture, despite what the patient is presenting. Mental checklists are consistent ways of simplifying complex situations. In this context, we're checking diabetes readings. This skill prevents you from treating readings as random. It's not trial and error thinking. The items on your list must be tested against observations over time, and from the information you gather, you'll see whether the physiology and pathophysiology explain what you're seeing. This checklist highlights diabetes biology and provides an example question, and we'll discuss a little bit more after that. Rising blood glucose typically increases insulin secretion. Question: if glucose is rising, what insulin response should I expect? And do the patient's observations support that? If the person has functioning beta cells, rising glucose should drive insulin release. But insulin resistance can make that response insufficient at the tissue level. If the person has absolute insulin deficiency, the expected insulin response won't occur and glucose will rise disproportionately. Your nursing task is to recognize which pattern is plausible and escalate risk. Fasting and falling glucose typically increases glucagon. Question. During fasting or overnight periods, is the patient maintaining glucose stability or are symptoms emerging? Connect pre-breakfast elevation to physiology. Overnight readings are shaped by hepatic glucose output, counter-regulatory hormone activity, and baseline insulin effectiveness. A consistent pre-breakfast elevation can suggest that overnight hepatic output isn't being adequately balanced by insulin effect. Acute stress physiology can raise glucose without food intake because the body increases glucose production and reduces glucose disposal to prioritize immediate energy availability. So here's your question. Is this glucose rise occurring alongside physiological stress rather than eating? Name the common ward drivers: infection and inflammation, glucocorticoids, pain, poor sleep, anxiety, immobility, and acute illness. The clinical skill is recognizing when diabetes readings are actually a sign of a systemic stress state. Medication context changes patterns because therapeutic insulin administration can reduce glucose quickly and can also increase risk of hypoglycemia when dose, timing, and intake don't match. Question for you. What insulin was given, when, and what glucose effect should that create right now? Anticipate risks. Hypoglycemia risk increases when intake is reduced or delayed, when vomiting occurs, when the patient is confused or can't reliably eat, or when timing of insulin and meal delivery is inconsistent. You also anticipate electrolyte effects in the appropriate context, particularly potassium shifts with insulin. Food structure changes patterns in after eating blood glucose levels and insulin demand. So, question. What kind of meal was eaten? Does the glucose pattern match its structure? Treat food as an exposure that predicts pattern shape. Ultra-processed, carbohydrate-rich meals are often absorbed quickly, producing larger and faster after-eating rises, particularly in insulin resistance. Meals dominated by fats and protein with minimum carbohydrate often produce a smaller and less immediate rise, though delayed effects can occur in insulin-deficient contexts when fat and protein are substantial. Noting these questions, consider this about diabetes to assist your reasoning. Diabetes mellitus and diabetes insipidus share the same presenting symptoms: thirst, polyuria, nocturia, dehydration, fatigue. That similarity is a trap because it tempts you to assume the same cause. Your job is to separate the words from the mechanism. Is the body losing water because it can't conserve it, or losing water because glucose is pulling it out into urine? Those questions and their answers lead to different assessment cues and different immediate risks. Name the mechanism and the escalation implication. Diabetes insipidus is a water balance disorder in which arginine vasopressin, ADH, is deficient, where the kidneys don't respond to ADH, so urine can't be concentrated properly. If the pattern is primarily high volume dilute urine with normal or not elevated glucose, the differential shifts towards diabetes insipidus physiology and urgent fluid electrolyte considerations. Diabetes mellitus is primarily about glucose regulation and tissue exposure to hypoglycemia. I did say hyperglycemia. In uncontrolled diabetes mellitus, osmotic diuresis can create genuine dehydration risk because glucose in urine pulls water with it, and dehydration can worsen hyperglycemia further by increasing physiological stress responses. This is going to help you go a long way towards preventing category errors and flagging the right risk pattern early. Pregnancy increases insulin resistance, which increases insulin demand, which can expose a compensatory limit. In gestational diabetes, pregnancy-driven insulin resistance often shows itself with after-eating patterns. Let's name the driver for that. Gestational diabetes, placental hormones progressively increase insulin resistance across pregnancy. Many women compensate adequately. Gestational diabetes is the situation where compensation is not sufficient, and after eating glucose exposure becomes elevated beyond what is safe for that pregnancy context. Now, organize your frame of reference. If the primary indicator you arrive at is urine concentration control and water regulation, you're thinking diabetes insipidus. If the primary indicator is glucose control and metabolic stability, you're thinking diabetes mellitus. Similar presenting symptoms, different system mechanisms, and different immediate risks. Let's set up essential mechanisms for what's happening. Simple physiology explains why readings change after eating and between meals, and clinical reasoning extends that into conditional branches you can apply on the ward. Blood glucose typically rises after eating carbohydrate. Meals dominated by fats and protein with minimal carbohydrate often produce a smaller and less immediate rise, but they can still influence glucose timing and may cause a delayed response in insulin-deficient contexts, particularly when fat and protein are substantial. The pancreas responds to the stimulus of eating and to the contents of what is being eaten by releasing insulin from beta cells. Insulin moves Insulin helps move glucose out of the blood and into tissues, supports storage, and reduces hepatic glucose output when external supply is present. Between meals, when food is not coming in, the pancreas releases glucagon from alpha cells. Glucagon supports glucose availability primarily by promoting release of glucose from the liver, including from glycogen stores. That pairing is the normal regulatory system. Insulin supports storage and use after eating. Glucagon supports supply when intake is absent. Diabetes begins when that regulatory system fails to match physiological demand over time. Now, distinguish types based on causation and the clinical patterns they generate. Type 1 diabetes is primarily insulin deficiency due to autoimmune destruction of beta cells. In that context, insulin is profoundly reduced or absent, and glucose handling becomes unstable without insulin replacement. The clinical implication is that glucose can rise disproportionately to intake, and insulin isn't available for stability. Type 2 diabetes is primarily insulin resistance first and then progressive beta cell strain. Insulin resistance means a given insulin concentration produces a smaller glucose lowering effect in target tissues, so higher insulin levels are required to achieve the same glucose control. Early on, the pancreas often compensates by producing more insulin. Over time, that compensation can become insufficient and sustained hypoglycemia appears. Many people with type 2 diabetes can have high insulin levels and high glucose at the same time. That isn't contradictory once you understand resistance and rising insulin requirement. In the micro case, if the medication chart includes metformin and insulin, let me say that again. In the micro case, if the medication chart includes metformin and insulin is prescribed as correctional coverage, the most likely underlying physiology is insulin resistance, unless there's a known type 1 history or another clear cause of insulin deficiency. Your role is to recognize that pattern logic, then look for destabilizing factors that push an insulin-resistant person into higher readings, even when nothing dramatic appears to have changed. Gestational diabetes is first recognized during pregnancy. The key orientation idea is that pregnancy changes baseline metabolism and insulin demand. Placental hormones progressively increase insulin resistance across pregnancy, which means the same insulin signal has less effect in target tissues. So the pancreas has to produce more insulin to keep glucose controlled. As we've said, many women compensate adequately. Gestational diabetes is the situation where compensation is not sufficient and after eating glucose exposure becomes elevated beyond what is safe for that pregnancy context. The ward-relevant pattern recognition is simple. Think pregnancy plus rising insulin resistance plus higher after eating readings. It can look like our micro case. Higher readings after meals, escalation across the day with thirst and fatigue after eating. The mechanism isn't type 1 autoimmune insulin absence, and it's not necessarily the same as established type 2 progression across years, but it shares the insulin resistance logic, higher insulin requirement, and a system that can be pushed beyond its compensatory capacity under increased demand. Why it matters is also simple at this level. High maternal glucose crosses the placenta and increases fetal glucose exposure, which drives fetal insulin secretion and growth effects. It increases the probability of complications for both mother and baby, depending on severity and control. For the mother, gestational diabetes also signals increased future risk. It's a marker of underlying susceptibility to insulin resistance and therefore higher probability of later type 2 diabetes. Watch the dedicated gestational diabetes material for its own focused coverage. Since we're looking at the mechanisms of insulin within the scope of diabetes, we better address a major modern driver of diabetes: carbohydrate-rich foods and carbohydrate-rich ultra-processed foods. Carbohydrate intake raises blood glucose and stimulates insulin secretion. The size and speed of the rise depends on the amount of carbohydrate, its form, and how processed it is. Ultra-processed foods are often digested and absorbed quickly, which tends to produce larger and faster after eating rises in blood glucose and higher insulin demand, especially in a person with insulin resistance. In contrast, meals built around fats and protein with optional greens eaten to the fullness commonly reduce carbohydrate load and slow glucose appearance in blood, which tends to produce smaller after eating rises and lower insulin demand. The clinical take home from this is that blood glucose behaves differently across different eating patterns, and that difference is visible in the readings patterns. Please note, with exclamation points if that helps, stress physiology, illness, and medication can raise glucose even without food intake by increasing hepatic glucose production and reducing peripheral disposal. Infection and inflammation can worsen insulin resistance and raise glucose. Glucocorticoids can significantly increase glucose by increasing hepatic output and impairing insulin effectiveness. Pain, poor sleep, acute illness can all push glucose up. In this micro case, the rising trend could be meal structure interacting with insulin resistance. But if the rise is disproportionate to intake or is accompanied by fever, tachycardia, new confusion, increased dehydration signs, or a general deterioration pattern, you treat infection or acute physiological stress as plausible and escalate. Don't be fooled by the apparent simplicity of diabetes readings when the real problem is an evolving systemic stress state. Let's look at therapeutic mechanisms and the monitoring implications. Getting to know insulin's role in diabetes also means there's an opportunity to alter physiological activity with treatment. The clinical idea is that you can change glucose patterns by acting on the treatment mechanism. That's the insulin effect. Tissue responsiveness, whether it's tissue sensitivity or resistance, or glucose exposure, which is meal-driven glucose load. Insulin is a powerful therapeutic mechanism because it lowers blood glucose by increasing glucose uptake and storage and suppresses hepatic output, and it shifts potassium into cells. Potassium status is inseparable from safe insulin management because potassium impacts electrical stability and cardiac risk in vulnerable contexts. You'll learn to anticipate insulin's effects, monitor what matters in the context of the patient's condition, and escalate risk early when patterns don't behave as expected or when the patient is clinically deteriorating. Metformin is a common treatment mechanism in type 2 diabetes management, uh, type 2 diabetes progression, I should say, because it reduces hepatic glucose production and improves insulin sensitivity. It doesn't have insulin's direct intracellular potassium shift effect. Metformin's practical risks are different. Gastrointestinal side effects that can contribute to dehydration if severe. Yes, that means diarrhea. Renal function constraints that require caution, and longer-term monitoring issues such as vitamin B12 status. Different treatment mechanisms act at different points in the physiology and carry different risk signatures and monitoring implications. This is how you avoid thinking that diabetes equals insulin therapy or that type 2 diabetes equals lifestyle choice only. Both are incomplete. Let's look at adaptive strategies and some common ward destabilizing factors relevant to our diabetes discussion. Our bodies have physiological responses that, when normal activities are limited or impaired, These responses produce recognizable clinical patterns. They're strategies. Sleep restriction causes the body to shift into a defensive metabolic state, worsening insulin resistance and supporting hormones that oppose insulin's effects, raising glucose and increasing variability. Shift work disrupts circadian timing, and timing changes glucose regulation and appetite regulation. Financial pressure, time scarcity, they change food exposure patterns, including access to whole foods versus ultra-processed foods, and therefore change after eating glucose patterns. Stress and shame change what people report, which changes how accurately they are assessed. Blood glucose trends can change quickly because illness and hospital routines affect physiology. Infection can raise blood glucose. Steroids can raise blood glucose. Pain and stress can raise blood glucose. Poor sleep can make glucose harder to control. Dehydration can worsen symptoms and can worsen readings. On placement, you see this often. The same patient has different readings on different days because their condition, medicines, pain control, sleep, mobility, and intake are changing. If this patient is unwell, in pain, not sleeping, or on steroids, and you expect higher, you, or on steroids, you expect higher readings even with the same meals. And this is why you don't look at glucose in isolation. You link it to observations, intake, output, and the overall clinical picture. The main risk with these patterns and strategies is high blood glucose happening often over time. You're not looking at just one single reading. Eyes, kidneys, and nerves are commonly affected first by long-term high blood glucose. That's why diabetes is linked with vision problems, kidney disease, numbness, and foot complications. Over time, diabetes also increases risk to heart, brain, and circulation to the legs. This is why glucose patterns must be taken seriously and why consistent monitoring and safe escalation matter. If a rising morning trend keeps happening, the body is exposed to higher glucose more often. Now, put everything into a simple clinical decision pathway you can use for monitoring and escalation. This aligns with your given nursing scope and ward expectations as you progress through placements and early career training. Identify which diabetes you're dealing with, mellitus versus insipidus, and do this by separating symptom language from mechanism and using urine concentration and glucose pattern cues. Identify the primary pathophysiological mechanism generating the patterns, insulin deficiency versus insulin resistance with progressive beta cell strain. Identify the major contributing physiological factors driving the pattern today: food structure, stress physiology, illness and inflammation, steroid exposure, dehydration, renal impairment, medication timing mismatch. Note to self, in pregnancy, unless you have clear evidence of insulin deficiency, you're thinking insulin resistance under increased demand, with special attention to after eating patterns, because that's where pregnancy-driven insulin resistance often shows itself first. Back to the decision pathway. And this is consistent, of course, for both pregnant and non-pregnant patients. Interpret readings across time rather than as isolated numbers and assess immediate safety risks. Risk of hypoglycemia when insulin is active and intake is inconsistent. Risk of dehydration when osmotic diuresis is likely. Risk of escalation when the pattern suggests deterioration and electrolyte risk in the appropriate clinical context. Then act within your nursing scope. Monitor, document, educate using mechanism language without judgment, and escalate according to the risk pattern and your local protocol. Back to the micro case. The presence of metformin suggests type 2 physiology is likely. Correctional insulin suggests transient high readings are expected or being managed. The rising pattern across the morning suggests insulin requirement isn't being met relative to intake and hepatic output, or that a destabilizer is present. You check infection cues, steroid exposure, pain and sleep disruption, hydration status, renal function, intake pattern, and medication timing. You consider hypoglycemia risk if insulin is used and intake is inconsistent. You flag persistent upward trends despite correction or symptoms suggesting deterioration. The practical meaning of your efforts is that you're preparing information and reasoning for the clinician responsible for prescribing decisions. I'm speaking as a biomedical engineer and nursing educator. My role is to prepare you to engage effectively on placement with your patients, colleagues, ward preceptor, clinical mentors, lecturers, and regulated clinicians responsible for safe practice. That means I stress identifying and reasoning through information you can test against what you see, intake and output, what the body signals, how tissues respond, and what risks are associated with readings over time. This channel will help you develop clearer observations, stronger reasoning, and earlier, cleaner escalation and handover skills. Make sure your diabetes knowledge becomes portable. Diabetes connects to vascular risk, renal function and filtration, neuropathy and pain pathways, skin integrity and wound care, infection risk, medication safety, and fluid balance. High glucose can drive osmotic diuresis and dehydration risk in uncontrolled states. Insulin and other interventions can change electrolyte balance and therefore electrical stability in the body. Diabetes is not a single silo of disease. It's a physiological event reaching out into every aspect of health and wellness. See you soon. Be well.